Hello? Okay, you guys, we're going to get started. Okay? Good afternoon. Today is November the 6th, 2024, and it is 1:31 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Yersinia, did anyone register to make comments for the Board of Managers meeting?
Yes, we have someone from DEI, Imelda. Is she in the room? Give me just 1 second.
Okay,
She is trying to log on to the Zoom link.
okay.
Sorry about that. Her computer had to do a quick Zoom update.
After this next person, sure.
Okay, I see Imelda is connecting her audio right now. Since it's an internal staff member, do we need to read the guidelines for public communication?
No, no, we don't.
Okay. Imelda, if you're ready, feel free to unmute.
Good afternoon, everyone. Can you hear me?
Yes.
Hi, thank you for having us today. I just wanted to share some of our highlights from Veterans Day from the DEI team. So, for Veterans Day, the Veterans Planning Committee decided that we wanted to do something to help our veterans who are experiencing homelessness or coming out of homelessness. Excuse me. And so we decided that we wanted to highlight Caritas of Austin, who have a very specific way of, and a very detailed way of how we can help our veterans who are experiencing homelessness and their families. So we have highlighted that and have informed our employees on how they could contribute if they would like to. We have also decided to highlight on some of the benefits that, or some of the services rather, from Central Health for our veterans. We have put out some information about MAP and how it could help them and their families. We've also put out other information regarding, crisis hotlines, emotional and mental health well-being.
Are you, are you present? We've lost audio, I think. Yeah.
All of that on
Recording in
SharePoint, and
progress.
we invite you to look through that.
Well, thank you very much. We very much appreciate this, but we're also wondering, would you consider putting that on our website and perhaps sharing that with us here today or us on the board?
Is there a way for me to share any of that, Yesenia? Like, I don't know if I could share my
Yes,
screen.
we can help you do that. Yes.
Sure. Do you want me to just share so far what I have on our SharePoint? I can do that gladly.
Yes, please.
Okay. Sure. Just a second.
I think, Chair, that it was the notion that maybe, Ted, that you were considering that we would follow up and get that to us by email? Oh, okay.
That's all right, Imelda. Ted is going to get back with you on getting this
Okay.
information. Thank you so much.
Sounds good. Thank you.
Thank you. And are there any other?
That is all for today.
That
Thank
is all.
you.
Thank you. And I believe our board manager would like to speak for a moment.
So managers and everyone, I wanted to make just a very brief statement for us this morning. I think I speak for many of us when I say, and I'll speak for myself, but I know I'm not the only one. I feel disheartened. I feel worried, and I'm afraid for the future of our country and the patients we serve. So I want to express that right now because I want to ask all of us tonight, this afternoon, to do what we normally do, but to do it with special care. Let's treat each other today with kindness and respect as we go through our conversations and understanding about how we may be feeling, even more than we try to do normally. So I just wanted to make that statement at the beginning and ask that of each of you. Thank you.
Thank you, Chair. Yes, Cynthia.
Madam Chair and Madam Vice Chair, are we going to be able to talk about this sometime? Thank you.
All right, thank you for your comments. We will now proceed to the committee agenda. Number 1, review and approve the minutes of the September 11th, 2024 Strategic Planning Committee meeting. Manager Valadez,
I move adoption.
thank you. And a second? Manager Kitchen, yes. Great. And number 2, receive, yeah, vote, yes. I'll take a vote. All in favor? Great. Thank you. Number 2, receive an update on Central Health Bridge Clinical Services. And I believe Dr. Shasha will be introducing his team.
All right. Good afternoon, board, and thank you for having us here. I am really excited to present the folks who will be sharing a little bit of the work that they've been engaged in. We are super appreciative of our EMS partners being here, Chiefs White and Carr. They have been instrumental to moving this initiative forward, and I think you will hear lots more as to the work that they've been doing, but their patient advocacy, their collaboration, their partnership, really central to our success in this area. And so we so appreciate their partnership. Sitting to my right, Monique Hamlin, Administrative Supervisor for our Bridge Clinic, and she will share some of what's been going on as well. Megan Clark, Director of Operations, Bridge, Transitions of Care, Respite, anything else that she touches turns to gold. And then obviously Dr. Kwong, who is our Director of High-Risk Populations. And I think you all have borne witness to some of the work that Audrey's already been doing, and they're going to share a little bit more today. So with that, I'll hand it off to you.
Okay. Board of Managers and Chair Kitchens, thank you so much for giving us an opportunity to share about the Bridge Clinic. What I love about being part of Central Health is that we get to see what the gaps in our community are, where the challenges are, and we feel empowered to address them. We feel supported to fix that, and I think the Bridge Clinic will be an example of this. Just 8 months ago, I was sitting in Dr. Shelsha's office and just talking about all the challenges between coming out of the hospitals, coming out from the carceral system, coming out of a nursing home and just feeling lost, and the back and forth between an ER and hospital, but nowhere a safe place to land. And we just kind of put all these things up. And this was just 8 months ago we were thinking about this, and I was like, yeah, we just kind of need to help fill the gaps. And my son was like, well, can you be just a filler, like a gap filler clinic? And thankfully, Dr. Shelsha was like, no, I think he came up with this great name. We're going to be the Bridge Clinic. And so next slide. So these were all the different areas that we were kind of thinking about, all these different areas where we have challenges in our community. And within about 2 months, we were able to stand up the Bridge Clinic. So today I'm going to share the different phases. We have 3 phases of the Bridge Clinic, which is really, the idea is like a safe place to land for individuals who are transitioning into or out of a care environment. And often they have fallen out of a care system and they just need to get back into care. And so this clinic is located at Capitol Plaza. So I'm going to start out with phase 1, which next slide. So as you know, our respite program is alive and well. We've been operating now for almost 3 years. Really we were trying to get them either into their primary care provider or set them up with a primary care provider, which was often taking a few weeks. And so I was able to welcome them into our clinic. We started in June 6th, seeing patients 2 half days a week. And just what I love is just there's so many wonderful things. One is that there's so much care on site. It's like a one-stop shop. So if you see this patient on the right, this is Gigi. She came to the hospital with kidney failure, renal failure, blood clot. She was in the ICU. Then went to the nursing home and then went to our respite program where she stayed another 8 weeks. And while she was in clinic, we were able to do an ultrasound right on site to check on the blood clot. She got to see the nephrologist in the clinic. She has since seen cardiology. She got an echo. I have never had a cardiologist call me with results. And the next day he called me or glipped me and told me. And so just that coordination of care is incredible. She's now gotten a lot of preventative care done, a mammogram, women's exam, all that good stuff. She got a pair of glasses while she was with us. She's since been discharged to Marshalling Yard, is still currently there while we're helping her apply for Social Security, being followed by the care management team and our eligibility team. And so that's just been really neat. The gentleman at the top is seeing our pharmacist on site, and you can see the translation iPad. And he's finally getting back into his diabetes care. And then that gentleman at the bottom, he is a patient that has cancer. He got to see our palliative care team. Also went across the hall and got an ultrasound. So just that care coordination. What I love too is the respite team takes care of them at our respite sites, but also was working in the clinic at the time. And so their face just lights up when they walk into the clinic. It's a familiar face. It's a very different experience than they've had probably in healthcare. And so, I think some of the common themes you'll hear today about Bridge Clinic, it's timely, the access is great, the coordination. Those are just themes that keep coming up. So in the phase one was about, we're continuing to see respite patients, but really started in June, continuing now. But we've seen 71 total visits in the first 3 months, with 2 half days, 41 unique patients. That's pretty much 90% of all respite patients have come through the clinic. I love to meet them at least once, and then we get them set up with a PCP in the community. So that was phase one of respite. Phase one of Bridge, really just getting to bring patients in. And I didn't know how they would feel, but they have loved coming to clinic. I think just it doesn't feel rushed or hurried. We take the time and they get to meet all the people. They get to see familiar faces from respite. So it's really made a difference and taken our respite care to a whole new level, to have a clinic where they can come and be seen. So that's phase one. So now I'm going to talk a little bit about phase two. Next slide. So this is about our partnership with EMS. And so I want our Chief Carr to talk a little bit about how that got started. But what we were hearing from the community is often patients would go to the ER sick and maybe get some treatment, but then leave and still feel really sick, and not feel better, but then not know where to go. And then we heard in the ER that it's really busy, people are coming, but they just need med refills. And so there's a lot of challenges in the community. So I'm going to pass it over to Chief Carr to talk a little bit more about what she was seeing and her colleagues.
Thank you, Dr. Kwong. Again, my name's Angela Carr. I'm a division chief with Austin Travis County EMS, and I would just like to say how happy we are to be here, and the opportunity is just so great. If we could move to the next slide, please. So as an EMS agency, obviously the community has grown to know that when they call 911, that someone will come and solve their problem for them or assist them with their emergency. And so as an EMS system, we work hard to deliver care to our patients, and we want to do the right thing for the right patient at the right time, right? So as we're working through interacting with our 911 patients, we get 911 calls and are able to triage them with an accredited medical priority dispatch system in order to determine an acuity of the patient and the call in which we need to send an ambulance. So we noticed in going through our data in in fiscal year 2023, we had about 65,000 calls that were in the lower priority category. So these were lower acuity calls. And as we interface with these patients, we found that approximately a little over 29,000 of those needed to be transported to an ER, or were transported to an ER. So that's a fairly significant number of transports. And we also found that maybe those patients weren't being best served in the emergency department. Like Dr. Kwong was saying, if you go to the emergency department and they address a life-threatening need, they will then discharge you and tell you to follow up with a primary care physician, and a lot of these patients do not have that. So we came up with a way to address these calls without sending an ambulance initially with the Collaborative Care Communication Center, and that is just testing. Better? Okay. So with our collaborative care communications line, we are able to disposition calls in different ways, alternative ways. And we're able to, move away from the emergency department as our only option for taking care of patients. So we're able to set up appointments with primary care physicians. We're able to do virtual assessments or doctor's visits, PAs. We can use community care clinics, Central Health, WellMed, or other private physicians. We also are able to use EMS physicians or PAs to disposition. We can deliver care on scene that is outside of the scope of a traditional paramedic, role. So wound quick care or indwelling devices, those kinds of things. We are excited to be able to now transport these patients to the Bridge Clinic in either an ambulance or in another vehicle that would allow us to keep ambulances available for the high acuity calls. And it's just a really eloquent solution to the obstacles that we're encountering. This isn't something that is a traditional EMS, operation or response, but it is something that we are passionate about and we feel is the wave of the future. And this is the way that EMS systems are going to be moving very quickly. So this allows us to save the rooms and the beds in the emergency department for the high acuity patients that need them. It allows us to have ambulances available for the high acuity patients when they call. It allows us to kind of interface with these patients without involving the police department. And again, just keeping the hospitals and the healthcare system available for those high acuity patients. Next slide. So as someone interfaces with the 911 system, again, the paramedics on the scene or through the phone can kind of determine their acuity. And then that paramedic will then transfer that call to the C4. And C4 will then triage further the need of that patient and then decide, what the best solution is for that particular situation. If the Bridge Clinic is the best solution for that patient, then we are able to interface with the Bridge Clinic and let them know that we're coming, ensure verification of eligibility, conditions, all those kinds of things. And then we're able to bring the patient to the Bridge Clinic in either an ambulance or another vehicle. And we're able to do the warm handoff, have a conversation with providers about, the obstacles that we've encountered, the medical conditions that we're working through, and then, hand that patient off to the Bridge providers. And again, we have just received nothing but ecstatic remarks from our providers and from the patients. When we don't have a solution for these patients and we don't have a clinic to take them to, we start that vicious cycle of taking them back to the emergency room, not serving their needs, putting them back out on the street. And again, that is not productive for anyone. So we are just so happy to be here. We're so appreciative of the collaboration. We're so appreciative of having another resource to offer to our community. And it's really just been a great step in the right direction. And we're looking forward to the future iterations of our collaboration. I mean, literally, the sky's the limit. So thank you.
All right, next slide. And I have to echo, I think it was refreshing to be at the table with someone equally as invested in coming up with a solution. So we also thank you. I don't want to not say that. But who is appropriate for Bridge Clinic? So of course our MAP and MAP basic patients, but we really wanted to make sure this was a low barrier clinic, especially for our patients experiencing homelessness. So people experiencing homelessness who don't have insurance, we have staff on site who can do the point of service applications real time, and then eligibility kind of on standby as well. So where the patient leaves, they have MAP or MAP basic and then get their medications or schedule their specialty appointments or get their diagnostics done same day or soon after, not have to wait for their coverage to kick in. And also mentioned Angela mentioned, approved by the bridge provider. So there is a very extensive handoff that happens between EMS and the bridge provider just to make sure they are appropriate. We don't want anyone who truly needs to go to the hospital to come to the clinic. We do also have a process in place that if they do arrive and they do need to go to the hospital, they can be safely transported to the right location. So exclusion criteria includes bedbound and wheelchair, and that's really only because we want to make sure we can get the patient back to a location, and our transportation requires 24 to 48 hours to set a bedbound or wheelchair transport up. So you do have to be mobile, ambulatory to come into clinic, but hoping in the near future we can make some changes around that. And then of course, the emergency medical needs, if they need to go to the hospital, please let's send them to the hospital. Next slide. And then just some common complaints, won't read them all, but dental pain, ear complaints, rashes, nosebleeds, all things that you yourself would probably go to your primary care provider to see. So want to make sure we are able to treat the right acuity in clinic. So these are some of the common things in those priority 4 and 5 that EMS expressed that they were seeing that we, yes, agreed to also see in clinic. Next slide. So this is our bridge team, also up here, and also in the audience as well. So I want to highlight Janice, who's our senior nurse manager, of course, Dr. Kwong, Monique, who will speak here in a minute, who's our amazing administrative supervisor, Matt Dang is our new operations manager, and then we have 2 providers coming in about 2 weeks that we're really excited about, Dr. Thomas and then Jennifer Nunez, and then we have 2 amazing MAs, Estella and Jalen, who just joined us. But as you can see, our team is going to grow over time here in the next couple of months, and we have 2 teams which I really want to highlight. So one team will always be in the clinic, and then phase 3, which we'll get to, will be a mobile team. And so understanding that being in the field as a mobile team can be pretty heavy. And so we wanted to offer the opportunity for our teams to switch off. So one team 1 week might be in the clinic, the next week they'll be mobile. And so have a time to regroup, refresh before they have to go back into the field. But recognizing there's needs in both places in the clinic and then also out in the community. Next slide. So this is the front of Capitol Plaza, which we're very excited we were able to house our clinic inside. So we wanted to highlight, we do have a separate entrance for our bridge patients that EMS uses exclusively, so it's off to the left, which has been great. So EMS is able to park right up front, unload the patient on the stretcher, or if they're walking in, come directly into that entrance where we can do an immediate handoff of the patient, get report out from the patient, the team can start interacting with the patient, bring them directly back to the room, do vitals in the room. And I want to highlight this as well. We didn't want someone who called EMS, which means they're clearly experiencing something in pain, and have to sit in the waiting room. So we're able to bring them directly back into the clinic, complete the check-in process in the clinic, the vitals in the clinic, start their MAP application if they don't have any coverage, also in the room as well. And as Dr. Kwong mentioned, it's been really nice to have all of the services at Capitol Plaza readily available, from labs to ultrasound to pharmacists. I think that's been a game changer because our patients are homeless, and so who knows the next time we'll be able to interact with them. So as much as we can complete those services in the moment, real time, is definitely our goal. And then something that Dr. Kwong advocated for, which has been great, is to have over-the-counter medications available for our patients. So they're able to get some common ibuprofen, cough syrup, diarrhea medication while also in the clinic, because again, when do we know the next time we'll interact with them? Are they able to make it to the pharmacy? Do they have cash for some of these OTC medications? So able to provide that while they're in the clinic. Next slide.
All right, so I'm going to just share 2 patient stories and then share some metrics with you. This was one of our first patients the first week. You can see he was brought in on a stretcher. He was found downtown, this gentleman, unable to walk, very weak, and had pretty extensive wounds on his legs. And so this is a night crew that came in the morning, around 8:30 in the morning. And we're just so grateful that they, decided to bring him here to the Bridge Clinic. And so in the first visit, his wounds were very terrible. He has severe eczema, hadn't been able to take his meds for 2 months, and it looked like he was having a pretty terrible secondary skin infection. So immediately put in a derm consult because I was sort of like, maybe I'm doing this right. And within an hour, I got a call or a response from the dermatologist kind of guiding some of the treatment plan. But we were able to clean his wounds. He pretty much slept most of the day. He spent 6 hours with us. Janice did about 2 hours of wound care. We got him some pain meds. I got him started on some antibiotics. He rested. And in hindsight, because I did get some labs, he was actually pretty sick. His lab showed that the infection was pretty extensive. He is definitely someone who could have gone to the ER, but really got some great care with us. And this was on a Wednesday, so I wanted to see him the next day, but we didn't know how he'd get back to us, so we told him to go to the Arch. Go there at 9 o'clock. Our respite team who's at the Arch will meet you there, get you in a lift back to our clinic, and that all happened amazingly. So he came back the second day. We got to clean his wounds again. He did some blood work at that time. He also got to rest, but he was definitely in better spirits and more awake. And then I saw him the following week. We went over his labs. I did need to give him another week of antibiotics. We did start his meds for eczema at that time, and then I set him up with a primary provider at community care. So these were 3 great visits back to back, and really just could not have happened on his own without a phone, without transportation. And definitely, the timeliness, the access, the coordination, and then just, not having to go through the ER was all really wonderful. I'll tell you about the next patient. Next slide. This is a young man, Spanish speaking only. He was fixing his flat on the side of the road, got hit by a car, multiple lacerations, road rash, pain. He went to the ER. They did a lot of x-rays, thankfully no broken bones, but still in a lot of pain, still probably very much in shock. Went back to the ER the next day, still with a lot of pain. They did give him some pain meds, but just still not feeling good. He called 911 again the next day, just didn't know what to do. And at that point, they brought him to the Bridge Clinic. So that first time I saw him, I started him on antibiotics because he was starting to have a secondary infection. We actually was able to do an on-site ultrasound of his hip because he was having a lot of hip pain, and did find a 5-centimeter hematoma. And I was able to prescribe him stronger pain meds. I saw him the second week, took out his sutures, did more wound care teaching. He's very achy, so we got him on a muscle relaxant. And then by the third visit, at that point, just got him into physical therapy. He's having a lot of trauma, not sleeping well, so he got to see one of our behavioral health consultants on site. Got him a referral to ophthalmology and dental, which he's done all of those, and now referred him to a PCP, which he now has an appointment to in a few weeks. And so this is the beginning when he saw us, and then on his last visit, now smiling and feeling a lot better. Okay, great. So I could talk on and on about lots of stories. I'm not going to do that. I'm going to now talk a little bit about some of the patients. So this is really just 4 weeks of our clinic being open, so still very new. At this point, it's 2.5 days a week. So it's me on Wednesdays and Thursdays and Dr. Patel on Friday mornings. I've taken out all the respite patients, which we're also seeing at the same time. And as you know, we're getting anywhere from about 0 to 3 to 4 calls a day from EMS. And so I just want to go through some of the demographics. So we've seen a total of 26 patients, or gotten 26 calls. This is the breakdown. So Black 35%, Hispanic, Latino 27%, and then white 38%. On the right, I know it's sort of small, but I wanted to just compare it to HMIS, Homeless Management Information Systems data in Travis County of 2022, and just kind of show how the demographics that we saw in the clinic reflect what's happening in our community. So in the community, and so HMS tracks all patients accessing homeless services. This was for 2022. That was 32% Black, 32% Hispanic, and 28% white. And I think I'm really proud that a lot of our demographics is reflecting what's happening in the community. I haven't really seen that before, not even in respite are we serving those kind of, that kind of demographics breakdown. For gender, you see female 39%, male 61%, and that also reflects what's the HMIS data, which also is really wonderful. I think what we see in the community at our clinics and even in respite is this 3-to-1 ratio, and so to see that reflected is really, really great. We did talk about how many of the patients don't have PCPs. You can see 85% had no PCP, 15% did. And then in terms of housing status, one individual was housed, one person came from Austin Transition Center, and then 93% were unsheltered. Next slide. So of our referrals, 76% came from EMS. We get about 20% from the community. Some of that was from a mobile outreach event we did at Hungry Hill. We also got some calls from Sunrise. And then the other clinic was GI is on site, and they had a patient experiencing homelessness that they asked if we could see and help, and of course we wanted to. So that's the other clinic. Of the patients that were referred to us, we approved 80%. 16% were declined. 3 of the 4 were because of their insurance. I'll tell you, we still helped them, and I'll give you a little bit about that. And then one patient was scheduled by EMS, but then they couldn't find them during that morning, but we also were able to help them, and I'll tell you a little bit more about that. Some of the top concerns in the first month were infection, whether it was their skin, a tooth infection, ear infection. We did see some patients for trauma, like assault, a motor vehicle accident, some GI complaints, nausea, diarrhea, and then med refills. And then the number one thing that we've been able to do is get them onto MAP. And like Megan said, we do have an expedited process, so by the time they leave, they have a MAP card in hand and it is active. Many cases, it does take about 6 to 8, some time for that to be active. But we have set up a system where Monique will then clip the eligibility team, and they will get them active right then and there, which is wonderful. We help them with transportation, med refills, over-the-counter meds, wound care. There's on-site labs, vision vouchers, and specialty referrals. So lots of great stuff happening in the clinic. And this is without our CHW yet. So once we have our CHW, there will be much more exciting stuff to happen. Next slide. So I want to tell you about the patients that actually didn't come to the clinic. So that was all the good stuff that happens in the clinic. This was the first patient, someone who was seen in the ER for a facial fracture. The community health paramedics found him downtown the day before and wanted to get him connected to care. So they called us in the morning and said, we have this guy, can we schedule him? And we're like, yeah, let's get him in at 10 o'clock. But then when they went back to Republic Square where he was, they couldn't find him. Meanwhile, Monique had called the CHW from the David Powell Clinic, who actually came to the clinic to hopefully meet the patient, but he didn't come. But that community health paramedic went out looking for him, and the following week did find him, get him back into care at David Powell, and actually got him on a housing list, Project Transitions, and got him a shelter bed at Marston Yard. So even though he didn't come into clinic, we were able to sort of break that cycle of, this individual not getting care. I want to tell you about a patient I just heard about yesterday that I didn't have a chance to talk about, but this is a gentleman that came to our clinic 2 weeks ago that Dr. Patel saw. He had been to the ER twice before for dehydration, weakness, got IV fluids, and the third time he was still feeling really weak. So called 911 again. And I think, it's very hard. He's just been to the ER 2 times and earlier in the week, and he's still feeling really weak. So we said, just bring him over to Bridge Clinic. So when he got to the clinic, Mo immediately got him onto MAP, which was great. And then Dr. Patel saw him and said, wait, I know he's weak, I know he's dehydrated, but he's also, can't feel his legs. And so she did a full neuro exam and was very concerned and said he needs to get back to the hospital. So that, within the next hour, we got him back to the hospital. She called the ER attending and said, I'm really worried about this guy. He needs an MRI. It turns out he had cord compression and probably, that's a surgical emergency. And so, great that she advocated for him. I'm sure that he was dehydrated the other times we went, but things had progressed. And now, it was good that he came to clinic and did get that a more in-depth assessment and then that call to the ER to say, please get that MRI. So then he's at the hospital for 2 weeks, and Dr. Patel just called us yesterday and said, now he's at our nursing home. She's taking care of him at the nursing home. And, down the line, hopefully we'll get him into respite. So I'm just so happy that we've got this whole network team. Wherever they are, we can connect the dots, and that's just been just so gratifying to see that our patient are getting some of that care that they need. This last patient, we got a call that this patient can't see, has decreased vision, and I was able to review the records. This patient does have a PCP, saw there an ophtho referral was placed, but this patient doesn't have a phone, so didn't know that the ophtho referral was approved. She just needed to call to get that appointment, so we were able to connect the dots there. Next slide. So just kind of reflecting on the first month, I think the first thing is that care is not finite. Like you go to your doctor, you go to the ER, you go to the hospital, but the care doesn't stop there. You don't feel better right away. And when you don't have a PCP or, support, it's really, really hard. And so it's something that we just really saw is that how much anxiety that you have when you just don't know where to go. I think that was so palpable to me, and that's something that I'm so grateful that we could really be there for that team. And you can see that it doesn't take just one visit and they're feeling better. Many of these patients come back for sometimes 3-4 visits and then getting them into primary care. And just the coordination of care that hopefully you saw with some of the specialists. Preventing ER visits and then getting them into care, either right then and there or with down the line. And just the power and effectiveness of connection. Monique has been in our community for 10 years. Everybody knows Monique. Monique knows everybody. And I will come out of the patient room and she's already made calls to get things set up for that patient. It's been really neat. And I think the power of this team and working with EMS and just all of us together, I have a lot more hope. I've been in our community for a long time, and this clinic gives me hope for the work that we're doing. Next slide. So on the horizon, this is really exciting. We will be moving to 5 days a week by mid-December with our 2 new providers coming. We're going to be able to offer even more procedures like IV fluids, paracentesis. I just want to shout out the great work that we did at CareCo with Dr. Shelsh's vision. I think this has laid the groundwork for the next level up, which is now, with this EMS partnership, but a lot of the great work that we have done here is because of the Care Connections Clinic that we started many years ago. And so those are the procedures that we got to do at CareCo and now bringing here. Co-locations of services, all the things I mentioned, but also very exciting is down the hall, in the same hallway will be MAT, Community Cares. MAT Clinic will be co-located with us, Dr. Weens and his team, and then psychiatry. This is Dr. Trust, if you haven't met her before. She is wonderful, and the director of mental health, behavioral health at Central Health. I pulled her in for a visit last week, and she will be providing services on site as well. She's already started 1 day a week and will be expanding. We're so excited to learn about this Pulsera platform from EMS, and that's really going to be a game changer in terms of how we all communicate. That's something that they already use with the hospital system, but now that Central has allowed us to bring that into our environment, we're really excited about that. And then also on the horizon is our mobile services, which we're starting in January. We've already started a little bit, so next slide. On the left is phase 1 and 2 at Capitol Plaza, but we know that we can't expect everyone to come to a brick and mortar. That's, care needs to happen everywhere. And so we're excited to launch phase 3 of mobile. Where we're going, we're still trying to figure that out. There's so many great community partners, so many places that we can serve. We're really excited about that. And some of our bridge patients, if they can't get back to us, maybe we can go out and find them in the community as well. So there's so many great things. And so now I want to just, let Monique talk about the work that she'll be doing with the mobile team as also admin supervisor. Just to give her a shout out, 10 years ago, she helped start the street mobile medicine program at Community Care. That was a lot of her vision, a lot of her work. And so when she started with us in August, at the end of August, I asked her to start a mobile, help us with mobile. And within 2 weeks, she was able to get that started with all her expertise and wisdom and everything that she's done. And so I'm going to give her a chance to talk about that.
Hello, y'all. We're almost done. Again, my name is Monique Hamlin. I'm the admin supervisor for our wonderful Bridge mobile team. And I just wanted to take a few minutes to highlight our first outreach event that we did at Hungry Hill. Hungry Hill is a place where those who are experiencing homelessness can go to, and they can get a bunch of different resources, whether it be clothes, whether it be they need their clothes washed, they can get connection with jobs, they can get connection with us, a bunch of different resources. So when we went and we did what's called a mini PERC. PERC stands for Pop-Up Resource Clinic. If y'all are not familiar with that is, typically out in the community, we partner with, or CUC partners with EMS, and they provide a PERC out to the community, and it's a bunch of different resources that come to that. At this one was sort of a mini vision of that. We were able to make some connections with folks. We were also able to have different partners come out, link. They were there to do coordinated assessments. We provided map cards. EMS was there to help bridge any other services that were needed. And then we were also able to schedule some appointments. Those patients came the following day to see us, and they have since come back. Like Dr. Kwong says, we're a safe place for them. They know that they can come see us without judgment. They know they can come for snacks. If they've been up all night guarding their tents, they know that they can come and have a place to rest so they can do it all over again the next night. But this is where we were at Hungry Hill, and you can see we took a picture in front of the rental car that we went out in. We were very happy, very excited about that. Next slide, please. And this was an event that we did about 2 weeks ago. This was at the Arch. This is their annual Winter Wellness Day, and they provide vision screenings, they provide glasses, they provide flu vaccines, and just a bunch of different resources as well. Although we were not able to provide medical services, we were still able to connect with our partners. We collabed with CUC. We had the case managers there, Megan Jansen and Pam Cavazos of CUC. They were able to schedule case management appointments. We were there to collab with our financial screeners. We were their cheerleaders. We got pretty much everybody that was there signed up for MAP. And once again, we were able to just collab with the community, show them that we're here, show them that, hey, we're here to provide whatever it is that you all need when you all need it. And then it's just fun. It's fun for us, and it's a way for us to keep our names out there. Our patients know that we're a safe place for them. And so I just wanted to highlight that. So thank you.
So yeah, that's what we wanted to share with you today. I wanted to end with a thank you to our EMS partners. We have been meeting actually every Friday just to kind of check in with each other. And again, their enthusiasm has just been wonderful to work with. I wanted to shout out our project manager, Shane Bass, who corrals all of us to meet and get us together. It's a lot of work, and so this couldn't happen without him. Our two amazing nurses, Kathy Tomlinson, Debbie King, and then just all the amazing teams, our legal team, our eligibility team, our Epic and data teams, our respite team, the Capitol Plaza team. It does take a village, and this could not happen so quickly without all of the great work of all of these team members. So I didn't want to leave them out without, saying a thank you to them. And then just the incredible support from Dr. Shelsha, John Morgan, Monica Crowley, and Dr. Lee as well. We're so grateful to be able to do this work. So thank you. And we'll take some questions if there's time.
Well, that was very uplifting on such a dreary day. So we could start with Manager Jones. Any questions?
No, one question, but first of all, thank you very much. You really are a blessing to this community and communities that are not always heard of, so thank you very much for that. My only question is, are you working with other, I noticed Hungry Hill you mentioned, are you working or reaching out or coordinating and linking with other communities? I know particularly we fund and have supported the Black Men's Health Clinic, and I didn't know if you all have like other connections with groups like that and or other groups that could benefit from that and need to know about you. So if you could just speak briefly to that, I appreciate it. And once again, thanks so very much for your work.
Yeah, no, we work closely with them as well. And a lot of it is when somebody needs to be set up with a PCP, we can use Black Men's Health Clinic. Any other things that we've done in terms of, again, Mo has connections to everybody. And if there's somebody that we need to connect to Black Men's Health Clinic, we actually know the case manager and community health worker on their end. But I think the biggest one is making sure they have a landing spot in a primary care home. And we've really found Black Men's Health Clinic to be a great partner in that regard.
Manager May.
Thank you. First of all, it may not be groundbreaking work across the country, but it feels like it's groundbreaking work for Austin. So thank you for that, because this is really phenomenal. I'm also very impressed with the work that's being done with EMS, the collaboration that you've got going on with EMS. That's critical, and thank God you all are working together. So thank you for that, and keep it up. Thank you.
Really moved and uplifted. Also appreciative of the collaboration. I was just speaking with the City Council Public Health Subcommittee today about my joint appointment here, and they were particularly interested in these types of innovative solutions and also how to better foster collaboration in ways that, frankly, can improve care from the patient side, right? Improve outcomes, of course, which is the most important, and also do so efficiently, and by being able to bring together collaborators and institutions who can get a sense of where their boundaries are and sort of have a good notion of how to share invested resources. I think it's really inspiring. When it comes to the C4 team, or the Collaborative Care Communication Center, or I guess the way the calls are received, it sounds like there's a pretty clear system now for how calls would get routed, the non-emergent calls that are low to medium, I might say, acuity, but then by EMS definition. Is there a way to direct refer or to maybe dog whistle special terms when someone's calling in to be able to ensure that they may be routed to the Bridge Clinic? Or are there ways to get referred in outside of it seems like it's the C4 center that would make a determination. Is there a way to kind of coax that determination into happening, or at least flag it?
So can you hear me? Is this working now? Okay, sorry. So we are looking at more ways that we can capture these patients and understand the needs. We are looking at expanding our C4 hours. So right now, our Collaborative Care Communication Center is only open from 7 a.m. until 10 p.m. We're looking at mid-January to late January to move to 24-hour shifts. So that is going to, I think, allow us to capture more patients. And as the calls are interfacing with C4, or paramedics from the scene are interfacing with C4, we're anticipating that there's going to be a lot of follow-up potentially. So anything that happens overnight or other connections that we can make are gonna be increased, absolutely. And the other things that we're doing on the EMS side is advertising internally. We have approximately 700 uniformed employees, and so this is a new system. This is a new resource. So we're ensuring that our providers internally understand who's eligible, how to connect them. So we're hopeful that those measures together are going to get us pointed in the right direction.
So it sounds like early days, limited capacity, and while we're scaling up, we're also learning about all the different ways that we can intake patients.
Chair Kitchen.
Just a quick follow-up on that. So, at this point, is it correct to think about this as the only resource that you have for EMS that diverts from the ED? So, in other words, folks that have insurance or perhaps have Medicaid, there's not a route for you to divert from the ED at this point?
We do have the ability to make phone calls and connections. If someone is already connected with a primary care physician
Okay.
and they're interfacing with the 911 system, then we can call their primary care physician no matter, where it is. We do have an established connection with WellMed. So
Okay.
we do refer patients to WellMed that they have established. We have a working relationship with them as well. But we do utilize our in-house physicians. We have medical direction that we are able to use on scene or online medical control where they're interfacing with them either via telemedicine. So we do have other options, but we don't have a primary care or a clinic option that is readily available.
Okay.
It's, situation dependent.
Okay.
But this has been a significant game changer because again,
Yeah.
we have to be able to disposition these calls in a way that is, reflective of the care that's necessary. And sometimes we don't have that option. So it's been amazing to have, that option for our patients.
Okay. Last question, just one more. So right now, this is a great option for the respite, so our folks in respite. As we move towards a respite facility at the, the interim one, and then Cameron. So there'll be clinic on site. So this will focus on folks that are homeless that need assistance and are not in the respite program. Did I get that right? Okay. All right. Thank you. Manager Martin.
Yeah, thank y'all for the work. And I really suspect that the MS providers get quite a bit of satisfaction from doing this work. I mean, it's uplifting instead of just dropping people off in the ER. I'd have a question, it segues back to the 24-hour thing. I'm assuming that when a patient is brought there, they are then established, there's an electronic medical system that can follow them. And does EMS have access to that on an iPad or a laptop or anything so they can look up the patient's history and see and coordinate?
That is actually something that has been very beneficial to us, and we've been working through having access to those records. And yes, we do access them on a regular basis, and it is part of the assessment process as we're interfacing with these patients. And again, that has been a game changer for us as well because the amount of information that we have access to has been tremendously helpful.
Yeah, thank you.
I want to thank you all for the work that you do, all of you, everybody, for the work that you're doing for this population, which was never really invisible, but was invisible to a lot of people. And so I really want to thank you, and y'all are blessed for this work. Dr. Martin already asked you about the data connectivity to follow the patient. I'm asking whether or not you are going to be, it looks like you could be outgrowing your little space there at Capitol Plaza pretty quickly. And so are there any plans that you have to go into some of the other facilities? Like Ann had said, the Cameron Road, that's going to be 3 buildings that we still are trying to figure out what's going to happen there. And possibly at the CUC building, which is the old children's building on 15th.
So yes, so I think CEC will house our medical respite clinic, which has been a large number of patients that we're currently seeing at Capitol Plaza. So all of those individuals will now move over to CEC, which will free up some capacity at Capitol Plaza for us to at least start with 2 teams, but having at least just 1 team in clinic and then 1 team mobile at a time. So for now, I think that is appropriate, but I can definitely see growth in the future, so we'll have to see where we land, but for now.
The reason I'm concerned about that is because I know that they're both along 35. One's on this side, one's on that side. But outside that boundary, we have huge homeless populations that have great needs in Montopolis and South Austin, and, you know, along the highways systems. And I just wanted to make sure that those future sites or little communities are also going to be, their needs are going to be addressed. And that we're not going to grow housed homeless communities everywhere, but just wanted to make sure it's much easier for somebody to get to access to care if you're closer, and not having to, especially if you're not in a car, you're homeless, you're walking, you're, you know, depending upon, you know, getting a ride. So I just wanted to make sure that you all look at
And I'll just
where
add,
your demographic is living and where they're going to possibly need a little substation. Thank you.
and I think our mobile teams will help support at least those pockets for now until we figure out where we'll land long term.
Dr. Lee?
Thank you, Dr. Brinson. I just want to add a note of deep appreciation. Having come new to this community, it has blown my mind how ahead of the curve our colleagues at ATC EMS are, probably years ahead of the nation. And that innovation always places people at the center, and is sort of fearless in breaking down the barriers. So thank you, Chief Carr, Chief White, Chief Lukritz, Dr. Escott, and colleagues. And thank you for inviting me to see the magic happening. For those who haven't seen it, you may not even be able to imagine what the communications center looks like. It's the size of a movie theater. You can see every major high traffic highway intersection and watch those hotspots in real time. And you have, you know, I'll get this wrong, but TxDOT, Cap Metro, police, fire, EMS, C4, literally in the same space, co-located, talking person to person, each person with 6 screens and multiple amazing digital tools and devices. And it is beyond cutting edge. So thank you. And to our internal team, you know, welcome, Monique. The ClinOps team that Audrey and Megan represent, but Alan and John and the colleagues behind them. There's an extraordinary collaboration that allows a whiteboard problem to become the Bridge Clinic, you know, in a few breaths. And that is amazing. And a particular shout out to my colleague, Alan Schulsche, for vision and action to turn the vision into reality. Certainly not Alan alone, but without Alan, I don't think this would happen like this. And the last thought I wanted to just mention is, I think at our retreat earlier this week, we teased the idea that one way to see the problem of health inequity is in the delay in care between the moment somebody needs something, something meaningful, right, and the time it takes to get the response and care they need, if they get it at all. And so I heard timeliness, access, coordination, person-centeredness. You know, you get your MAP card before you leave today, 8 weeks ahead of schedule, right? Those kinds of delay eliminating interventions are profound. And I have the hypothesis that if we were to eliminate these delays, we would also eliminate the inequity. And so I just want to just say how deeply grateful I am for the work you all are doing. Thank you.
I would hate to follow that, follow that, yes. Okay, so number 3, we're going to receive an update on the strategies learned from the City of Denver related to services for people experiencing homelessness. And Dr. Pat Lee, Megan Clark, and Lucas Bostello will be presenting.
So I have the privilege to just kick off, and then I will hand over to my colleague, Lucas Bustelo. Many of you have likely seen Lucas, in the room for our retreat, but you may not have heard Lucas's voice, and so I'm so excited that you get to do so today. Emily Ferris gets the credit for recruiting Lucas to our team, so this is a huge thank you and appreciation to Emily for finding Lucas. And Lucas, in his very short time here, has brought both himself, right, as someone from Puerto Rico who found his way through a large health system in Florida, and then consulting with GuideStar, working with Guidehouse. Thank you so much, Guidehouse, which had helped us with our healthcare equity plan, working with ARC, and then with us. And it just has been a wonderful addition to the CEO office. So you'll see some of Lucas's work, and you'll recognize that a lot of the materials that actually come before the board have passed through Lucas's hands. So I'll just cover this first couple slides. So we were invited by David Gray to join, next slide please, to join a 30-member delegation from the city of Austin to the city of Denver. And so you see on this list here the members of that delegation, Commissioner Ann Howard, ACM Stephanie Hayden Howard, council members Ryan Alter, Vanessa Fuentes, Zoe Quadri, and Jose Velasquez, the Homeless Strategy Office led by David Gray, Housing Department led by Jamie May, ECHO, community advocates, and we were invited to join as well. So it was really an honor to be there. Next slide, please. And we visited a range of locations throughout Denver. Denver is a city-county, strong mayoral system where there is no city manager. So the mayor is the mayor, city manager, and county judge kind of all rolled into one, and has declared ending unsheltered homelessness as the number one priority for the city and county of Denver. State of emergency, like we had in COVID, is declared, and twice daily an emergency operating center meets to work the problem. So what you see here is just a sampling of the combined healthcare and housing site at the Colorado Coalition for Homelessness, a community support organization, the Denver Dream Center, interesting and safe outdoor spaces, and the Lawrence Street Shelter and Community Center, and then affordable housing, the Sanderson apartments. And so we've got a sampling of that range, and I'm going to hand over to Lucas to walk you through some of the key observations. And then when Lucas is finished, just hot off the press today, we received this summary of feedback from David Gray's office, and I'll close out and hit a few highlights off that to finish up before I would take questions. So Lucas, over to you.
All right. Good afternoon, board. Thank you for having me. It's an absolute honor to be a part of this organization. As Pat mentioned, my career has been along the lines of large health systems consulting firm, but finding Central Health was a blessing in terms of what this team is doing, the people they serve, and more importantly, how they accomplish that. I think that's a very important aspect to that trifecta, and I think the Bridge Clinic discussion really brought that to light and how we're addressing a lot of those populations. So interestingly enough, I'm going to cover what Denver showed us via our trip and our time there. This first slide is meant to illustrate mainly what was driving their strategy, and this encompasses top, bottom, everything we saw in those last locations that we discussed. So encompassing what drove their initiative, we bucketed 8 items that led to their strategic success in their efforts. So going along the lines, without touching any smaller points, they had a strong sense of long-term commitment. So it wasn't a sense of we need to address this year and the next 3 years. It was a long-term play. And more importantly, with that long-term play, they had the collaboration of all entities within the system, the health system, community members, shelters. There was a holistic understanding that in order to address this problem, we needed to come together. If not, somebody or somewhere there would be a gap that was left unaddressed. There's also a sense of housing first philosophy. So not looking at just treating the patient, but really identifying what is the appropriate means of caring for them. So that housing first mindset really contributed to some of the efforts and the progress that they made. Additionally, they had integrated service delivery. So along with housing solutions, they also had integrations for clinical services, but more importantly, they also had social services, vocational services, anything that really would address the need of the person, not just the patient. And I thought that was a very, very holistic way of looking at the situation. Additionally, they also have innovative funding mechanisms, diverse housing options, a focus on prevention, and data-driven decision-making. I think all of those aspects speak for themselves in terms of the benefits that they provided. But again, all those things had to come together, and not one aspect was more important when considering the problem as a whole. Next slide, please. Now, as far as takeaways, there are three main areas where we did see, and I'll kind of touch on these again, but again, that very first takeaway was the amount of commitment and investment that was done in order to make this all possible. So a little bit of a history take. So in the early 2000s, the city began to invest in their infrastructure related to the location of their FQHC and some of their shelters. So from the get-go, they had a strong mindset into identifying this as a need in their population. Fast forward to last summer, the first day in office that the Denver city mayor had, he enacted a state of emergency, which declared that by the end of his first year, he would bring 1,000 people off the streets. And not only did they succeed, they surpassed. So they were able to get about 1,200 people off the streets in a year, averaging about 100 people a month, 3 people a day. If you break it down in that sense, that is amazing. But again, the only reason that was really able to be carried about in the last year was because that focus was made, that infrastructure was built over decades in order to allow for that system and that thought to happen, right? Another takeaway, again, centralized and integrated services. One of the things that I very much enjoyed in the Stout Clinic was seeing how integrated their services were, not only just the housing aspect, but the social work aspect, the clinical workers aspect. So it really felt like one system. It wasn't a part of you're going to option A, then B, then C. It was a cohesive process. So talking about that continuum of care, where we're not letting that patient fall through the gap of the handover process. That's such a cumbersome thing for somebody who's not used to the health system to deal with. And especially with this population where there's so many uncertainties, being able to address them as a human, it goes a long way in such a small period. And lastly, flexible funding and diverse housing options. So the funding options that the city of Denver had came through multiple different sources compared to how Texas acquires their funds for. But they also, in the housing side, leveraged a different strategy in terms of their coordinated entry process and how they select patients for their housing services. But again, they also looked at innovative ways to address it. So one of the places that they mentioned, but we didn't get to visit, was a farm property where not only are there fields, but there's also a lot of land. So there's potential to not only grow and develop, but also it was used as a rehabilitation spot in the sense of, okay, let's remove a lot of barriers. Let's get you back on your feet. Let's give you one purpose, which I thought was a really unique thing to say, and saying, hey, you know, there's more to life, there's options, what can we do to get you to where you want to be? And I think that part of the conversation was missed, but ultimately was one of their most booming sites. It was filled almost immediately in the first quarter, and it's continued to thrive since. So again, looking at ways that we can address this problem in an out-of-the-box way should be a focus for us going forward, but it's something that I noted from the city of Denver. Next slide. and again, I'll mention, so I think a common theme in healthcare, especially at this level, is the need for case management. And I wanted to highlight that because although we do want to highlight the work of physicians, the work of executives and such, it really does come down to that smaller level of who's interacting with that person day by day. And and by they I mean Denver in all its capacity, relayed that importance of having that touch point, of having that person who's really caring for and about the patient. So noting where that stands, that's one of the areas where I noted, in Austin, maybe we can focus on addressing that need, maybe looking at other ways that we could leverage that resource. But ultimately, the last one goes into collaboration, where, again, I do believe that a strong sense of synergy needs to exist between all entities and all parties. So the city, the FQHC, advocates, the Homeless Coalition, there has to be that sense of understanding that we're going towards a common goal. We're not siloed and executing independently to hope it all works together. Next slide. Okay. Now, in integrated service coordination, one of the areas that I believe was worth calling out here is, as we just discussed with the Bridge Clinic, there are a lot of opportunities for us to integrate services. The discussion here was closely related to how Denver involved their clinical services in their housing solutions. So what role can we play in terms of providing services to patients in independent housing solutions? Again, those housing solutions could be traditional in the sense of apartments or facilities like the farm that I mentioned, but also looking at that coordinated assessment and the tenant selection criteria. There may be a lot of opportunities for us to look into how we conduct that search. And I think David Gray's team is doing a great job at kind of getting us together in terms of identifying that piece of the puzzle. And then community engagement strategies. Again, I'm a big fan of treating the person, not the patient. And one of the big stops that we made along the way was this entity called the Dream House, Denver Dream House. And amongst a lot of its functions, one of its main things was peer support. So it was individuals who have experienced homelessness, who have been able to go through the process of rehousing, kind of fixing themselves up and saying, you know what, I want to be that shining light for somebody else. I want to provide that opportunity for them to see that there is a chance for you to be whoever you want to be and wherever you want to be. But to have that golden light was so enlightening. We did a walk with them across, around the community to see people hand out food, hand out water and supplies, but really just to see, okay, what does this interaction look like? And that in itself was as beneficial as seeing people in the clinics. I mean, it completely changed my perspective, at least, to what the problem and its realistic nature is. So I found that to be something that's worth a highlight. And in the vocational department programs, another call out I'll have is one of their shelters had this large kitchen used to not only train people on kitchen skills, organizational skills, time management, but also served a synergistical function in the operations. So it also provided food for that shelter and the shelters next door. So it provided that build-off opportunity to say, you're not impacting just this small circle, we're really looking at addressing the community, right? So those are some options that I believe we could easily implement or try to address in our future planning, but created a lot of positive benefits. So I'll leave that there. The next slide, please. And now challenges. Off the bat, one of the big differences that both cities, Denver and Austin, have is the funding sources. Colorado has additional tax revenues that Austin and Texas do not take advantage of. But includingly, there's also the discrepancy in Medicaid funding. So as you can see on that slide, so Colorado has a 70% allowance on Medicaid versus us who have 30. if anything, it translates to me as an opportunity for us to, again, think outside the box and how do we address that disparity, that gap of 40%, because we can also find creative ways of addressing said benefits in the meantime. And the other challenge, which I think we discussed in the last presentation, which was the geographic spread. A learning lesson that we gained from Denver was similarly to Austin, as they addressed the city center population of unhoused people, they noticed that it's spread, but in smaller areas. So now it's not oh, here is that population, it's where are they and how can we get to them? So we had time speaking with the respite care team as well as other members of the community, like how do you bridge that? The mobile team was a huge part of that. And in addressing that, I would say one of the big things, other than a brick and mortar location, was our reliance on that mobile team and addressing people not only how they are, but where they are in life, geographically, anything like that. And I think that's a very important touch, especially to that point. Next slide, please. Okay, and final thoughts. Just preach and repeat myself. I think one of the biggest takeaways was the collaboration. It's that sense of this problem can be addressed. It's not impossible. It is an uphill battle, but we all have to be aligned in terms of, again, the city, the health system, the advocates, and the community on understanding what the problem is, how can we address it, and what is our role in addressing it. As an update to this, I'll also say we've had a great time with the Homeless Strategy Office reviewing what the debriefs have been thus far. We are planning on meeting start of December timeframe to debrief as a whole again with the council members and other entities to figure out what is our FY25 plan. How are we going to be addressing this short term? Because, taking advantage of this initial idea is, I think, critical. The longer we wait, the less it kind of has effect in our minds. So getting on the board early is key, and then really looking at who takes ownership over different areas of the problem, I think will be key, because we all shine in different ways. I don't mean to shine from anybody. I want us to shine together. So I think these meetings and these conversations are crucial. And yeah, I'll bring up Dr. Lee to summarize the summary document.
Thank you, Lucas. So again, hot off the press, this one-page front and back document you have, this came from David Gray earlier today. When we returned from Denver, David sent out these 5 questions to all the participants, and this is the summary of those 5 questions. I'm just going to hit a couple highlights, and you're welcome to read through in entirety. Question 1 was, what were your top 3 takeaways, insights from Denver's approach to homeless services? The top themes in order were leadership, priority, and coordination across the departments and community. Number 2, sustainable funding streams from tax and diverse funding. Number 3, strategic plan of performance indicators and data dashboard. Number 4, robust case management that follows the client, coordinates healthcare and other resources. And number 5, having a short-term plan with aggressive goals. Question 2, what additional insights did you gain regarding Denver's approach to homeless services that you believe are applicable to Austin? Underlining that first comment that Lucas mentioned, the strong leadership and coordination across all departments of the city and community partners. An overarching theme was the great need for increased access to mental health, behavioral health, and physical health care. Everyone appreciated the services are readily available for clients. And there was a call out around the connection between the health clinic and PSH housing that we saw in that large FQHC where they did all of the above. Question 3, which specific projects or initiatives from Denver do you think could be successfully implemented in Austin, Travis County? I'll just call out blue boxes, things that were mentioned multiple times. And the very first thing on that list is a facility that includes both health care and housing in the same facility. Question 4, are there any projects or initiatives from Denver that you believe would not work in Austin? What factors contribute to perspective? The geographic spread was called out again, so right on point, Manager Valadez. And question 5, is there anything else you want to share about how this trip influenced your perspective on addressing homelessness in Austin? Last two quotes here. Being together with so many policymakers and decision makers on the trip gave me a lot of hope that we can use this trip as a catalyst for change, doing better with the resources we have and increasing our resources. And a big thank you to David Gray and the Homeless Strategy team for planning and coordinating this wonderful trip to Denver. Not only were we able to think and dream big after seeing the Denver system, we're grateful for the conversations and ideas that were sparked amongst the delegation, excited for all the policies that will follow. And we'll use the last word to sort of call out the two concrete next steps that we are following, including working more closely with Matt Malika and the ECHO team around HUD voucher allocation to a medically vulnerable special population. We're already beginning to take some early steps there together. And then the question of whether the Colony Park development could be a place where we consider combining clinical care and housing. So question mark and to be determined as we follow up with our city colleagues. So thanks for the opportunity to share this deep report out. Thank you, Lucas. Thank you, Audrey and Megan Clark for joining us on the delegation. And we would love to hear your thoughts and questions.
Chair Kitchen.
Thank y'all for this update. This is great. I think you've picked out the key things. And you know, when I was on city council, homelessness was something that was a top priority for me. So it's an area that I know quite a bit about. But I also want to remind us all that it's probably time, I'll say this to Dr. Lee and everyone, it's probably time to take another run at that collaborative effort. You all may remember that earlier in the year, there was an effort to bring together the us and Integral Care and Dell and the city to do, I think it was on one of your slides, to create that collaborative relationship. And for a number of reasons that didn't work at the time. Appropriately, it didn't work at the time. So, but it's needed. I think we all recognize that it was needed, and we said that as a group and made a commitment to participate in that. So, well, I know you guys are probably thinking about this, and maybe Monica has something to update on that, but it's time to take another run at it, and whether that's something that we need to lead on or whether or not the city is ready to come back to it, don't know. But that's really, really important. The other thing I just wanted to say is what's different about Austin and Denver is the funding. That is the bottom line thing, the funding and the public communication. The city of Austin has never done a good job of explaining to the community what all is being done. A lot of these things are being done, but nobody knows about it because the city has never done a good job. The city also doesn't have consistent commitment across years of councils, and part of that's just because there's no committed funding, and the funding has to come up each time. So that's been part of the issue. So, and there's some other things that you highlighted that I think are really important, like the flexibility on the coordinated entry. That would be very helpful. And what we're doing and what you have led, Dr. Lee, and where's Dr. Kwong? Anyway, on this respite program, this community has never had this robust respite program before. And what's really huge about that is the following the person all the way through to permanent housing. That has not happened in a consistent way before either. It's talked about a lot, but it doesn't happen. So I'm very excited about where Central Health is and the stepping up to the plate that Central Health has done. And so I just wanted to make those comments. And I know Monica knows a lot about this from her work in the community. So she's been doing that a lot longer than I have. So is there something you wanted to add?
Yes, thank you so much, Chair Kitchen, and thank you for this opportunity to revisit the collaborative work that started and then stalled at the beginning of this year. Assistant City Manager Hayden Howard brought together a slightly less formal group that Dr. Shalsha Perlikavasos and I have been participating in with Integral Care, ECHO, Travis County Health and Human Services, and the City of Austin, Austin Public Health, Housing Department, and the Homeless Strategy Office have been participating in for the past, I guess, 6 weeks, where we are going through kind of more collaboratively all of the different kind of projects and programs that we're working on related to homelessness. Our first meeting was kind of just we're reconvening in a slightly different way. The second meeting, Matt Malika and his team from ECHO came in and did a presentation on their funding streams, how they work with HUD, the Continuum of Care Coordinating Committee, so kind of the ECHO programs and sources of funds. Just yesterday or Monday? Yesterday, we were at the city, and David Gray walked through the $273 million that the city has spent over the past 3 years addressing homelessness and the different sources of funds and different types of both capital and ongoing programmatic investments that the city has made and is making. Next month, the ECHO is going to be presenting a little bit more, and Travis County is going to be presenting, and then following that, Central Health is going to present to the group on our investments in homelessness. And I think it would be a great opportunity after all of the different collaborators come together, maybe for us to bring something back to the Central Health Board, kind of like the collaborative presentation that Megan and Audrey and the EMS teams did.
Yeah, I would just ask, I'd make a request of our chair that that there be a presentation to us so that we can hear what each of those other entities are doing. I know that may be challenging to collapse it down to something that's digestible, but I think it would be real important for us to hear that, because what's happening here in our community right now is helps arm us to understand when we can take advantage of what's happening elsewhere. If we don't know what we're doing here, we can't really do that. So maybe that can be an item. Yes, definitely. Thank you.
Manager Valadez.
I don't know how old you all are. I don't think I'm the oldest person here, but I could be. So you're talking communal living. And I was a young child when that was going on all around. Anybody that was progressive or liberal or community oriented. They lived in communes, or they lived with populations, communities together, families, extended families, et cetera, and addressed issues and problems in that manner, especially in what was appeared to be a farm-like setting, because you were growing your own food. You were, taking responsibility for the entire community, not just the individual. So I'm glad that you're seeing that. I would have liked for our chair to have been on this trip.
I was invited, but it was during the time that I was out.
Oh, you were?
Yeah.
Mm-hmm. Next time, take the vice chair. If the chair can't make it, we have a vice chair, people. Okay, so, and the reason I say that is because it's very good for the understanding and the conversation to occur between the board and the staff and the other entities, because this is something that I have asked Mike to participate, for anybody who's going to listen to me again for the 20 billionth time, that, the city has the county, the city, that, and who is a city council member and a state representative, and here now sitting on the Central Health Board of Managers, knows that there is a group that meets, and Central Health is the only entity, in my opinion, that's not at the table to work with the other government agencies to address our local global problems together, and make sure that everybody has an understanding of our shared responsibilities and also our shared knowledge as we bring each other up. There may be things that we don't know that's going on, like Ann said, and there are things that they don't know that Central Health may be doing. But I'm very appreciative of the fact, Dr. Lee, that you're starting to attend, I'm assuming, If not, and if you can make sure that Central Health is sitting at that table, if they've got
I think we will,
ACC,
between Dr.
the
Lee and
county,
Monica
the
and I.
city, yes, they've got everybody there, the school districts, but they don't have Central Health. And we are a taxing jurisdiction, and we have access to dollars. So I greatly appreciate that commitment to homelessness, because as you do to the least of your brothers, our brothers, so you do unto us. And as you bring up the least in a community, so you bring up the rest of the community. So I welcome you to Central Health. I thank your expertise, your experience in other areas, so that we can benefit from what you have to offer. And thank you. Thank you all.
Thank you. Yes, sir.
Sorry, I appreciate those words. I just wanted to say, to that point, one of the things that I did notice was it did seem like the first time that Central Health was kind of brought along into the conversation during this trip.
That's right.
I don't have any historicals on that, as I just turned 3 months old here. But one of the key things and intangibles that's not captured here was that relationship building and the time that we spent with every single person on that delegation to really establish, hey, Central Health is here not only for the patient, for you as well. And I think one of the big things that I cared to tell the team was understanding that continuum of care. Where does Central Health lay, and where do we have connections? The truth is, as a health system, we have touch points throughout. So there's no reason for us to be segmented from the discussions and everybody else. But to your point, I think we created a lot of really great relationships. I think the conversations are going to keep going. I know one of my duties now is kind of following up on those conversations and making sure that we're delivering on our side. But I have full confidence that from here on out, Central Health won't be left out. And I'll thank Dr. Lee on his great work there.
Thank you very much. Any other questions?
Without repeating, I think everyone's gratitude and positive impressions, I think that I would benefit greatly from some perspective, and I think this is also in line with the comments made by Manager Valadez and Chair Kitchen. I would benefit from a quick and dirty understanding of sources and uses from all kind of governmental institutions, stakeholders. And if that could be, it doesn't need to be too profound, easy for me to say. But one of the good things about working with government or quasi-governmental authorities is the ability to trace sources and uses all the way through. So, even a high-level SAN key diagram, I think would help me learn. And again, I don't expect this to be taught, or anything like that. And I know that those of us who are doing the work and in the meetings are deep diving in that way and understanding kind of what our boundaries and purviews are, where our overlaps might be, where traditionally dollars have been able to have been routed from certain sources to certain types of programs, etc. But when you're looking at housing and the spectrum of services provided in housing, and then homelessness and the spectrum, of course, of the continuum of homelessness and the continuum of care then associated that intersects with those things, there are lots of dollars that overlap or don't. And it would be good for me as a board member to have a better sense of that to help guide, I think, what our fiduciary and then, of course, moral imperative is, and it help orient that in as much as how we continue to collaborate.
And thank you so much, Manager Montwani, and I think that will be, Dr. Chair Brenson, something that I think we will be bringing back. Even gathering the information across the providers as a community is something that, to Board Chair Kitchen's comments earlier, has been something that has been a challenge to do. And so the conversations that are happening now, this is the first time that even kind of at the working level that we've had insight into, kind of what the other investments from the other government organizations are, including federal HUD dollars that come through ECHO to other kind of community providers. And so I think once we get through the next couple of months, that we can bring back that kind of high level look at, maybe we can do another famous spaghetti style diagram of the sources and uses and the different organizations and entities and how they fund programs. I don't know how Manager Valadez would remember the spaghetti diagram of the flow of funds that come from different sources for healthcare. And I think we could also do that for housing, as well as provide some narrative to, where things are woven together, where things have to be separate because of different regulations, and where we have an opportunity to really collaborate together.
Yeah, that notion around restrictions is also something I think, given, for example, just the world that we're in today, as opposed to yesterday, understanding restrictions on funding and how we can best leverage, the dollars we have, especially when there are options, and as much as how they may be applied. Thanks, y'all.
Any other questions? Yes, Manager Jones.
Thanks very much. Good opportunity to meet you. One of the challenges of being in Austin is that we have a tendency to like to meet and discuss and pull all kinds of groups together. Well, not together, but to have different pockets. And the challenge with that is that when we sit down to talk about what we should be doing, we don't bring all of that synergistic expectation to those things. My group or my committee or my initiative is what I'm working on. And oh, by the way, I will tell someone over here that we're doing this, but we don't. We attempted, at least I, along with others, attempted to begin a process, at least in the area of public health, by creating this Public Health Commission. The whole goal of the commission was to bring together all of the players in the area of public health to begin to set policy, program, and activities. What I've heard here today is it sounds like something around an area of public health, not the only area, but certainly one of the areas. So I guess what I want to say is that as we look towards pulling these things together, let's not create another group that's going to be doing something around, let's say, homelessness, that does not construct with what's going on with public health and housing and others, so that we don't end up spending a lot of time and resources going towards things that really could be more synergistically done. I just want to say that, not to be negative, but just to imply that I've been here long enough to understand how things operate, and I'm just a little concerned that we don't sidetrack on that. So thanks very much. I appreciate the. Did you do any skiing?
Unfortunately not, this is hiking though. No snow yet.
All right.
And Manager Jones, thank you so much. And just so you know, the working group that we've been participating in is less, kind of, I think the Public Health Commission that Perla and Megan Cermak regularly attend as the ex officio Central Health members. There are, all sorts of meaningful conversations that are going on in that commission. And I think these other meetings are kind of a continuation of almost the staff that would be working together to actually implement the, kind of joint and collective programs together, and to collaborate together on kind of next steps, actually pulling together things like the vouchers, the different, making sure that we aren't, kind of duplicating funds or crowding each other out in funding opportunities. So I think, Manager Valadez, to the recommendations that you have been making for almost as long as I've been working at Central Health, this is something where really on a very meaningful working level, we are collaborating and looking at, and Dr. Kwong is a great champion who's brought us a lot of kind of credibility and goodwill in these groups, so that there is trust that Central Health actually can deliver on, collaborating in these projects in a way that's very meaningful. And so, we're layering on almost to that Public Health Commission advice and counsel, additional, I guess it's that next level down of kind of day-to-day working staff level work that can actually, implement the programs and drive them forward.
And that's great, but it goes back to my question with the inception of the commission, was why was there not a public central health person put on, or persons put on the commission? It's good that we have supporting staff, but Central Health is one of the largest, if not the largest, public health agency in terms of health services here, and we should be part of that. So that's why I agree with what you're saying. I'm just saying I think that we could have even a bigger picture at the policy level if we had representation there.
I think, I would like to learn more about the Public Health Commission, so at the appropriate time, it'd be useful to hear more about what that entity is doing. I know, Shannon, I'm familiar with what you were interested in as you helped initiate that. I don't know what's happened with it, so that would be useful. Yeah, and so that's why I think it would be useful for a report out to us about who's on it, when it meets, what it's doing, stuff like that. So.
Just one more comment. Mayor.
Dr. Valdez.
Monica, you're very correct that with the staff's involvement in this new initiative, old idea, but new to action, because there was no political will before. It's a fact. There was no political will. And I'm really so pleased with y'all for taking these initiatives on and for bringing them to the table and participating now in Spanish instead of ya después de atole, after it's made, you're going to join the picture, but no, you're going to expand on the vision and make sure that all responsibilities are covered. You have HACA, you have the city and the county both have it. I used to be a fair housing specialist out of the federal office in Fort Worth. So I traveled and I had subpoena power and I could see the good that could be done, and I saw a lot of bad that was done with billions of dollars. So we're in a unique position because we have the political will right now. And if you could just get the staff to understand, just because the elected officials come and go, the vision is going to die. Make sure that they understand, no, this is actually part and integral to the quality of life for Travis County. Thank you.
Thank you. No motion is necessary. Yes. Oh, sorry. Yes.
With something very exciting, and that gives me a lot of hope. Being in the community for a long time, and just kind of seeing this shift in our community of hearing about having Central Health at the table. And I think a lot of it is reflective of Dr. Lee being in the community and making a lot of connections. And so people that I've been working with, I will go into a meeting and they were like, we just met Dr. Lee, he's wonderful. And so we came back on Wednesday. I think my flight got in at 10 o'clock. Thursday morning, I got an email from ECHO saying, we would like to rethink the coordinated assessment, which I've been talking about for years, of we can't just go by that. And to hear Denver say, oh yeah, we do go by that 50% of the time, but we don't always go strictly by it. And I've been trying to say that for so long. And finally ECHO, which, yes, was like, oh wait, we think that maybe we need to prioritize medically vulnerable. And that was the first time. And I think it was, and then they set up a meeting, ECHO set up a meeting with us and RBJ Senior Apartments. We had a chance to visit a week ago. They want to give us us, X amount of units for respite patients so that they can get housed. And we were like, this could be really cool. And then tomorrow we're meeting with HACA to think about how we can marry that with vouchers. So lots of exciting things are happening because a lot of us were in Denver with that synergy. And I know a lot of things we talk about, but I actually feel like things are happening. So I just wanted to end on that really happy, exciting note.
Just to close out, I think the last couple of comments have been really key to this point. In terms of planning, there are sometimes like 3 questions that you can ask yourself, and it's, is it the right person? Is it the right place? And is it the right time? I think historically, if I'm hearing correctly, maybe we're the right person, maybe it was the right place here in Austin, but it wasn't the right time. If this trip showed us anything, and hopefully this presentation brought to light, I do believe that we have built not only the infrastructure in the city, but also the capabilities in our system to be able to address this problem at the time. So I do believe we are the right person, it's the right place, and it is the right time for us to have these conversations. And to your point, Manager Jones, I don't feel any sort of way in terms of this conversation dropping itself off. I see it only continuing because everyone has that same mindset. At least that was my read in the room. So again, I'll thank you all, finally. I'll thank you all for your time and just say, this was hopefully the first of many presentations. I very much thank you for introducing me to this board, and I appreciate all the feedback and comments. So looking forward to working with you all in the future.
So, our last number 4, confirm the next strategic planning committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, December the 4th at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Manager Valadez and Manager Kitchen, both first and second, and then vote, please. All in favor? All right. Okay, great. Okay, thank you.
Okay, everybody. Let's see. Good afternoon. Today's November 6th, and it is 3:21. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. For our first item is discuss and take appropriate action on an update regarding Sendero Health Plans, financials, and proposed business strategies. And I believe we need to do that in executive session. Is that right? Okay. All right. So I'm reading the item. Discuss and take appropriate action on an update regarding Sendero Health Plans, financials, and proposed business strategies. I announced that the board is convening in closed session to discuss agenda item number 1 under Texas Government Code Section 551.085, Governing Board of Certain Providers of Healthcare Services, and Texas Government Code 551.071, Consultation with Attorney. Okay, we're going to go into closed session. back. Okay, it is November 6th at 4:05, and we're entering open session. We have a motion related to item number 1.
I'd like to make the motion, please.
Yes.
I move that the board approve the resolution provided to the board members authorizing Sendero to form a new subsidiary as recommended by the Budget and Finance Committee.
And this is the resolution that's in front of us, right?
In the packet, yes, ma'am.
Okay, with the red line changes.
Correct.
Okay, second from Manager Valadez. All in favor?
Aye.
Aye. Okay, the motion passes. Do we have any abstentions? Oh, I'm sorry. I didn't think to ask for that. Manager Jones, abstention. All right, we're ready to move forward. Oh, you want to pick up the packets? Okay. I should have done that at the end of.
Or should if I had known to take them, I would have.
Okay, managers, we're now going to move on to item number 2, which we're taking in open session. Receive an update from the Central Health President and CEO on the status of the fiscal year 2024 Wins for Trust. I'll turn it over to Dr. Lee.
Thank you, Chair Kitchen. Thank you, board managers and colleagues. I'm really just honored and thrilled to have the opportunity to kick off this presentation and then to invite my colleagues up to build. Next slide, please. When I had the privilege of coming back to this body at about 100 days into the job, one of the invitations was to really frame what I'd heard, really establish trust as a cornerstone of how we would move forward and as a basis for whole person care, to propose an ethos or a direction of one trunk, many branches as a way that we would partner to accomplish these broad goals, to give us a sense of where we stood. You may recall a SWOT analysis at that point, integrating the SWOTs from multiple executives.
Excuse me just a minute. Manager May, can y'all move off? We're trying to listen, so. Did y'all finish? Okay, that's right. Go ahead, Dr. Lee.
Thank you so much. And then to really think about what are the immediate areas for early impact. A lot of orgs think about quick early wins. We reframed that a little bit to early wins for trust. And then we went ahead and formulated 6 early wins for trust, whittling down from a list of perhaps 20 in active conversation with many of you and with our executive teams and our team members across the org. So next slide, please. Those 6 early wins that were intended to really drive that positive change and establish that early focus on trust included expanding access and equity around specialty care, expanding support services around respite care, focusing on employee satisfaction through people and culture, to unify our healthcare entities and create enterprise alignment, to strengthen community partnerships across inmate health and jail diversion, and to really improve alignment on priorities and budget through our board and community support. We had gone ahead, next slide please, and specified each of these 6 areas and described what threshold, target, and stretch outcomes might look like for each of those areas. And I'm delighted to report that in 5 of the 6 areas, we exceeded our stretch threshold, and you'll hear details shortly. In one of them, we fell below our threshold target, and you'll hear about that as well. At a high level, the one that we fell below, you'll see the first takeaway for us is really to just recognize that employee engagement and a sense of meaningful work and cohesion is something we can never take for granted. We had a decrease in some survey participation. We did find still a very strong signal around meaningfulness, but so there's strong engagement, but there are multiple areas where we need to drill down, understand what is it about this moment as we grow so rapidly, as we are experiencing some tensions within our system, and many of our executives are working very busily to manage those tensions and perhaps less able to be as present across the whole range of our system as we need to be and want to be. So we're going to be doing a lot of deep reflection around the one area where we didn't hit the mark. we also just want to underline how important alignment and communication across our partners, both within the system and outside of the system, are essential. Really simplifying some of the communication and then going again and again and again through roundtables and community conversations and follow-ups through our elected officials and our with our community stakeholders and advocates. In the end, we receive support from very important stakeholders in the community who have not traditionally supported our budget, and we did receive in the end a positive vote from all 5 county commissioners. So that was a key takeaway for us. And then to think about, kind of return to the people topic, how do we incorporate a focus on employee well-being and morale and growth throughout our strategic plan and goals going forward. So you'll hear many more details from our leaders as we go through and reflect on kind of the performance in each area and then learnings from those areas, and we'll just step through all 6 in order. So without further ado, next slide, please. It's my privilege to hand over to Dr. Shelsha and John Morgan. Get us started here.
Good afternoon, managers. John and I just wanted to touch on the fact that while we may sit in front of you and have the privilege of presenting the successes that our teams have had, it's exactly that. I think we spoke to that earlier today. The work that is done is really based on the teams, and very seldomly, do facilities or legal or HR get to sit in front of you and celebrate their work. Our success is directly dependent, on that collaborative approach. Clin Ops specifically, John is even starting to dress like me. We spend way too much. So actually, Pat is starting to follow that trend as well. But we spend almost every minute together for, to represent clinical ops because it makes sense. And our teams follow along and do that. So again, we're going to present the successes, but it is really their work that gets us to this point. With that, I'll hand it off to John.
Thank you, Al. So I have the privilege and pleasure of reporting out on our FY24 early wins goal around specialty care. As you all know, many of our patients have suffered for quite some time with a lack of access and a lack of timely access to certain specialty care services. And so this board, I think, has prioritized specialty care for a number of years. And this year was really a focus on creating some dedicated long-term capacity and access for our patients that we could start to solve some of those problems. I'm pleased to report that on our range of expected or projected volumes of patient services in FY24 from 3,000 to 5,000, as Dr. Lee mentioned, this is one of the areas that we've been able to exceed that stretch goal, that stretch threshold of 5,000 encounters for a total over the course of FY24 of just over 5,800. This year was really about getting our toe in the water, and I think we will have some exponential growth in terms of the service volumes, the capacity, and really the good that our teams are able to do for our patients and members of our community. In addition, we were also able to exceed the stretch goal of establishing 8 service lines. In fact, we have over a dozen that are up and operational today, and I'll speak a little bit more to that. But in all of our updates, we're going to speak to you about key takeaways, lessons learned, and kind of next steps in addition to just the numerical report out that you see kind of rolled up into one number. But we do want to keep that one number idea just to keep everybody's focus, keep our eye on the ball, and make sure that we're doing the things that we set out to do each year with the direction of the board. So my 3 takeaways on specialty care are pretty simple. The first one is that we have really amazing teams. The second one is that this work is incredibly complex and there are a lot of uncertainties. And I think the third one is that we have incredible teams. So I will expand on that, but I will also just reflect on the Strategic Planning Committee meeting from earlier this afternoon. I think it was a bit of a blessing that this conversation was delayed a couple of times, that you were actually able to hear about the Bridge Clinic and one of the services that are represented here that came online that really wasn't even one of the anticipated specialties at the beginning of FY24. I mean, the Bridge Clinic did not exist in concept even at the beginning of the fiscal year. So as one of the newer service lines that have come online, I think it's a really good example of the complexity of the services that our teams are standing up and executing on, and again, doing real good for real people in our community and in our programs. Another area of complexity or uncertainty that, just as a reminder, you all are aware that we experienced some significant delays in terms of construction and the opening of the Rosewood Zaragoza Clinic. And I think part of the message to highlight there is it would have been very easy for our teams to sit back and just say, well, we're going to wait until that clinic is open. But I don't think that was an acceptable answer for any of our team members. And all of the teams, and I can't point to a single person in this room that didn't have a hand in it, but all of our teams, all the folks that are represented here, really came together and pivoted to bring on not just one alternative site, but two. So instead of at the end of fiscal year 24 reporting out on the services of one specialty care clinic, we have 3 in operation today that have all been stood up over the past 12 months. So we're very, very grateful to all of our partners that are here in the room and those that are not, whether it was procurement, our facilities and real estate team, our technology team, everybody had a hand in bringing that together. So just want to recognize those teams. So the volume that you see here, the 5,800 patient service visits are from, again, over a dozen different service lines. The majority of that volume, not surprisingly, comes from the service lines that we started earlier in the fiscal year. So podiatry, gastroenterology, pulmonology, and nephrology are the majority of the 5,800 encounters, including, and this is an important distinction, the procedures that took place associated with those specialties, the diagnostics that are available in a comprehensive one-stop shop environment for our patients, so that we're not asking them to go somewhere else to receive those important diagnostic services. But in addition to those 4, you saw the Bridge Clinic at Strategic Planning Committee. We've started psychiatric services. We've started a behavioral health and psychotherapy service line, a surgical and medical optimization or a pre-surgery clearance service line, palliative care, infectious disease, dietitian services, clinical pharmacy services, women's health and sexual reproductive health services for tubal ligations, and cardiology here recently. But in addition to the actual service lines and the basic office-based clinic services, there's also a depth of programmatic development that takes place. We just last week provided our first video-supported visit through our EHR, through MyChart, and having video-supported telehealth capabilities is something that we expect to grow into a lot of different areas. We've provided care to Travis County inmates in our specialty care service lines. We've been bringing those on incrementally with a goal of, again, extending every specialty service line that we offer to our inmates. We've also even taken advantage of some of our specialty care services to supplement the care that's available in skilled nursing environments where our patients are housed and where we're also practicing medicine. It's not part of this report out, but extending specialty care into those other environments is a pretty big deal and a significant enhancement of what's available. But I also want to highlight, in terms of the lessons learned, that there's a lot that goes on behind the scenes just to develop the capability to practice medicine. And that's been a lot of what this year has been about as well. So actually turning on an electronic health record system for our patients, building some of that healthcare infrastructure, starting our navigation center for patient appointments, for nurse triage, for referrals, for health information management and patient records, our patient advocacy group. We've got a lot of pieces in the background supporting this work taking place. And again, I just want to end with highlighting the collaborative work that has happened across teams at Central Health to really bring all of this work online. In terms of next steps, and I'll try to be brief, but I could go on all night just on this one slide. This year is really a shift from building the airplane to now we are both building it and flying it. So this year is a shift to stabilization, to building scale, to building redundancy, and building the robustness of our service, the comprehensiveness of our service. That could mean data sharing, that could mean quality analytics, that could mean any number of things that really round out the service that we're providing to our patients. It also means more work in the programmatic space, building out additional diagnostics to support what we're learning. As you could tell from the presentation at strategic planning, every patient that comes to us is a unique set of circumstances, and we try to learn from those. We adapt based on the feedback from the teams that are in the clinic seeing patients and what they are identifying that they need. And as a result, that spins off several initiatives in every one of those service lines. So we try to be responsive to those needs as they come up as well. We need more providers. We are grateful to our partners at the University of Texas and the medical school. Many of these specialties are staffed with physician time from UT, and we are continuing to recruit additional physicians with UT to build that capacity. Part of the building the plane while we're flying it is while we are stabilizing and scaling these specialties, we will add a few more over the course of this year. That includes endocrinology, that includes rheumatology. Neurology, I should say, is the one specialty that's was on our plans for FY24 that we were not able to get off the ground. So we hope to fix that problem this year. And then extending in our procedural space, where we were really focused on GI as our procedural specialty in FY24, extending into general surgery and other procedural specialties coming into FY25. In terms of building additional depth, we're going to look at, again, more diagnostic capability that we can build in-house, whether that's FibroScans for patients in our GI clinic, skin substitutes being available for our podiatrists, infusion capabilities available for our patients in GI and endo and derm and rheumatology, looking at opportunities to advance things like home-based sleep studies so that our patients don't have to go to a lab to do a sleep study overnight. We can try to bring care into our patients' homes or into our respite environment where that's appropriate. And then we're going to continue building out some of the infrastructure as well. We just heard from Sendero, and one of the challenges, one of the things that we need to fix over the next few months is making sure that we can continue to see Sendero patients as we transition them from MAP into a Sendero product. Right now, we don't have the infrastructure, but we will soon, and have a goal of bringing that online in the beginning of the year. You've also heard tonight about our patients who transition to Medicare and into Medicaid. We want to make sure that we can provide continuity for those patients, particularly staying focused on the dual eligible type programs for low income individuals in certain plans. So we'll continue to pursue that Medicare and Medicaid enrollment and contracting with those payers, but we want to do that very carefully, very strategically, so that other payers, other folks who may have other options don't crowd out the reason why we're doing this to begin with, which is to create that dedicated capacity and access for uninsured low-income individuals in Travis County. And then from a facility standpoint, those 3 clinics are very quickly going to be out of space. I think that was pretty visible as we talked about Capitol Plaza earlier, where we have specialty care, we have Bridge, we now have community care moving in also to provide MAT services, all co-located in that one clinic. The East Austin Clinic is a shared space with community care as well, and RZ will ramp up very quickly and be at capacity. So you all are aware of the development efforts around the Hancock Center and the significant expansion of specialty care that will happen there. And just like we needed bridge sites to get to Rosewood, Zaragoza, we'll probably need some bridge capability to get us, capacity to get us to the opening of the Hancock Center. I think the CEC is probably going to provide us some options that are temporary, but and lower cost, more cost effective, cost efficient opportunities to build up services for the opening of the Hancock Center. I'll stop there. Alan, anything you'd like to add?
Just maybe elaborate on one of John's points. John mentioned that we haven't been able to get neurology up and running. We've had a few applicants, for that specialty. What we're trying to be really purposeful with is hiring talented providers who are mission aligned, especially when we get a service line up and running. And so GI is a great example. I think there are 1,400 positions across the country for GI providers, and we need additional GI providers. And so we are competing with institutions that are academic, that are, like Parkland, 125 years old versus our 20. And so in some ways, that's our rate limiting step, and we will be opportunistic. So if there is a specialty that we need and a provider who really is mission aligned and qualified, we may consider setting that specialty up and providing additional access for our patients in that line of service. Next slide, please.
I would just like a point of order. This is a great presentation as go on. We have a very important topic that we have to take action on that will run us, I believe, beyond our time frame.
We don't have any more action items. The rest are informational items. Because we did the Sendero one, which was the only, but that doesn't mean that, we do have informational items that are important for a conversame.
Item 4 is not an action item?
No, item 4.
It's written as action.
Yeah, item 4. Let me take a minute and explain.
Well, we don't have to delay. I just want to make sure because I may have to leave before.
Yeah. Okay. So it's an informational item. The action item that you're thinking of related to that will be taken on the 13th.
Okay. All right.
So okay. Yeah, I should have explained that earlier. I apologize. And yes, we're supposed to conclude at 5. Is that what you're thinking, Shannon?
Yeah, I've scheduled something that required me to leave at 5. So.
Okay. So this is a very important item. So the details you're providing are really important. You might consider if you want to take half of these with detail and then defer the others, or just keep going and we'll see how we do.
I promise my colleagues are not as long-winded as I am.
Well, it's important.
We'll pick up the pace.
Yeah, the other thing is, y'all, we do have 2 other informational items, one of which may require some conversation, and they're both in executive session. The number 3 people may want to have some conversation around. Number 4 is more of just a heads up informational item. So I imagine that we need about 30 minutes for those. So we are going to go over a bit, but why don't y'all see how you can do, and again, Dr. Lee, I don't want to compress, this is important information, so think about how you want us to do this, if you want more detail on part of them and rest of them at a later date, or shall we just keep going? So.
If it's okay, why don't we just keep going, and if we reach a certain point that we're approaching 5, we might defer 1 or 2 to the next time. I want to give each
I know.
In the midst of a lot going on, our teams have stayed laser focused on the 6 most important areas of trust, and I'm really proud of what our teams have done, and we would love to share that with the board in sufficient depth. So I don't want to constrain our executive report, if that's okay, and if we need to move some to the next meeting, then that might be the best move.
I think we all agree with that.
Okay, thank you.
Okay, keep going.
All right.
Medication crisis for my daughter.
Okay, that's okay, Cynthia, that's okay. Keep going.
All right. I promise I will not be as long-winded as Mr. Morgan. Respite is our second area. Respite, obviously, we've spoken quite a bit about. It provides an opportunity for individuals to rest, recover, and heal, and also to be connected to social services. Our goal in this area is really to have individuals utilize the beds that we have available for the entire year, and also to get our bridge services up and running. Now, at the beginning of the year, we had about 10 beds. We knew that we had a much greater need than 10 beds. And so if you look at our goals, if we filled every bed every night, that would be, 3,650 bed nights or utilization episodes of that individual bed. And so we set our targets high because we really should be utilizing those beds all the time. What happened over the course of the year is that we were actually able to contract for additional beds. And so not only did we fill these beds, but we added those additional opportunities. And so overshot our stretch goal. Some of the, and I'm going to go into some of the lessons learned because we've spent quite a bit of time talking about respite. Number one, contracting for beds is unpredictable. We don't know when organizations will have beds that are available for us. The other thing that we learned is that turning over those beds is not necessarily an advantage to our patients, right? And we've spoken before that it takes about 4 to 6 months in order to connect our patients to some of the social services that they really need. What we were able to do by adding beds is we went from about 37 days per patient to 42 days per patient. And then we did need to turn over that bed because we had a more critical patient who needed that bed. But we were successful at connecting many people to many social services, but there is a much greater need for additional beds. The third point is that the organization that we contracted for or with has its own culture, its own rules, and its own regs. That coupled with our patients, where our patients are in their life, meant that either individuals self-discharged from the respite environment, or they were discharged because they broke rules. And that gets us to some of our next steps, the need to own and operate our own respite beds, where we can create the culture, the environment, the rules and regs that really cater to our patients, so that if they still have an addiction disorder and haven't beaten that disorder, we invite them back in and we give them as many chances to succeed as they need. Obviously, we as a team walk the CEC. That is being built out, and we will take additional beds, and those will be owned and operated in addition to the contracted beds. So we're not going to give up those contracted beds. We will continue to build out. In addition, we're going to build out the Paul Bass Clinic so that the patients that are there can receive clinical services on site. We're looking at some of the addiction services that also need to be established in close proximity to our patients. Is it detox? Is it working with patients with alcohol use disorder? Is it providing our patients with some of the long-acting medications, that will help them progress in their addiction disorder? And so lessons learned over this past year, we're reinvesting in our patient population, and we'll take the next step over the course of this next year. Any questions?
Let's keep going.
All right, so next up, I have the privilege of handing over to Jeannie Verdon, our Enterprise Chief Human Resource Officer.
Good afternoon, managers. So as you can see, and as Dr. Lee already stated, our threshold goal was 80%, and we were just under that for the people and culture. So next slide. what contributed to that? So what we learned, again, the survey we held over a 2-week period in the early part of October, so just last month. And although survey participation was high, it was lower than it was last year. But again, 93% of our team members do find the work that they are doing is meaningful. Some areas of concern or dissatisfaction that we were able to theme out from the results. Obviously, this was a year of change, a lot of change, inclusive of rapid addition of new team members and service lines. There's concerns about return to work or return to office, I should say, initiatives. And then most specifically, as you will see in the next goal, we had decided that we were going to, in order to bring our system together, align on our market adjustment process, which we successfully did. However, community care was not in a place to provide market adjustments for all roles, so we only provided market adjustments for key roles, which means that a majority of our team members did not get market adjustments this year in a year of high inflation, leading to high dissatisfaction. So what are some of the interventions that we are going to be doing? We're going to be engaging with our people partnership team to work with leaders that have higher levels of or higher areas of dissatisfaction. We're actually going to work with all leaders, but really focusing in on those that had lower ones. Action planning and interventions cannot and should not be the same. So we really want to have that individualized approach. We want to update or establish wellness initiatives for improved mental and physical well-being. We want to have collaboration and educate on benefit programs that impact well-being. We also want to update our rewards and recognition program to make it more meaningful to team members. So really focusing on kind of that total rewards, full wellness, financial, health, professional development. And then we're going to bring recommendations back to the executive leadership regarding the return to office considerations and enhanced total rewards programming and benefits overall. Happy to take any questions.
Okay, we will keep going.
Okay, thank you.
We'll come back for questions at the end, if that's okay.
So next up, Stephanie Lee McDonald, our VP of Enterprise Alignment and Coordination.
Thank you. I am here representing a lot of different dimensions of our organization, many key executives, some of whom are in the room, and their work. I think we did achieve our stretch goal. However, there are some lessons learned. The areas that I want to kind of recognize up front, the TPA arrangement with Sendero went online, is going good. Okay, thumbs up as of October 1. And also, I think an acknowledgement that our Unified Branding campaign, I think we're seeing more and more of it, and it's been exciting to see everybody start to embrace it. I saw some teal-colored scrubs the other day. So I think exciting work there that really is helping us come together as a system. And if you can go to the next slide for me. What we learned, and I think this is the first time, and I think we need to acknowledge that this is the first time that Community Care, Sendero, and Central Health came together as executive leaders to create goals specific around eligibility and colorectal cancer screenings. There is a lot of work in the implementation of that, so we're very aligned on kind of acknowledging where there was synergy and where we could work together and where there was alignment to come and to make sure that everybody benefited from the goal. The work to implement that goal, to make sure that the organizational changes that are required, I think that is taking longer, and I think that is why they're in yellow on the slide previous. We are still working. I want you to know that. I think we have a couple of months left. We are cautiously optimistic that we might get to green on some of those, but I do think there is a lot of room for us as a system to align with our partners and our colleagues over at Community Care. Thanks.
All right. So next up, Monica Crowley, our Chief Strategy Officer and Senior Counsel.
Thank you, and I'm giving you the update on inmate health and jail diversion, and we also achieved our stretch goal in these areas. Just as an update from the last time we presented on this, we were able not just to implement one additional specialty care line in addition to podiatry, but we also implemented specialty care before the end of the fiscal year in palliative care and infectious disease services. And we now have a patient scheduled for cardiology. And as John Morgan said a little while ago, we're also looking to expand telehealth specialty services into the jail and potentially some of the services we contract for with our providers now. And related to the diversion pilot, we participated along with Integral Care in the ribbon cutting on the 15th Street Therapeutic Respite site last month, and they are starting housing people in November in that, not housing people, but placing people in that respite, therapeutic 90-day respite diversion site this month. Next slide, please. In kind of looking at the areas in yellow on the previous slide, we don't have to go back to it, but one of the things that we've learned are that the areas that are the hardest to achieve are the ones where we are working with partners beyond just the sheriff's office and the jail. And so if there are areas like with substance use disorder services trying to get longer term methadone in the jail, because we do that through partnering organizations, that's still yellow. So even though we are making progress on those talks, in the areas that are green, those are areas that we went into the work with almost 100% alignment on where we were headed and what we wanted to do. And then also you need to make sure that you have a real, as you're kind of ramping up the work, that in addition to the project management, that you have regularly scheduled meetings, not just on that kind of working level, but also on the leadership level, so that if you become stuck in an area, that you have a place that you don't have to go out, try to schedule 6 weeks out a meeting with the sheriff, because people's schedules are busy. So just making sure you have at least kind of quarterly, periodic, higher level meetings in place is important from the get-go. And then, again, just making sure that, you acknowledge that if you are aligning, the more partners you're aligning with to get the work done, the harder it is to, take them from red to green.
And last but certainly not least, Perla Cavazos, our Deputy Administrator. And Ted Burton, our Chief Communications Officer.
Hello. So we're going to be just giving you a quick update on board and community support for strategic priorities and budget development this early win. And really the purpose of this early win for Trust was to get alignment and support with our board of managers, with community stakeholders, and with elected officials around our strategic priorities and our budget for fiscal year 2025. And I do want to acknowledge that it was more than Ted and I. We had all executives and their teams involved. It was all hands on deck. And so I just also want to acknowledge everyone's hard work. We were able to achieve all of the deliverables that we set out to do. And I'll just kind of run through those. Of course, there was a formalized process to receive board input into the budget and priorities and budget. When we began meeting with Travis County commissioners early on, in probably 5 months before, it seems, before budget adoption, we involved board of managers in those one-on-one visits, and I want to thank those of you who made time to attend those visits with us. We actually did 4 rounds of meetings with each commissioner. We engaged monthly with elected officials. So, you know, every few weeks we're sending some type of communication by email, generally by email, but we're also on the phone and doing those one-on-one visits, giving them updates on what Central Health is working on, and updates about our board meetings as well. We coordinated, Ted's team specifically, oh, hold on, let me skip. We coordinated we actually did 5 presentations to Travis County Commissioners. I think we set out to do 4, but because our budget vote was postponed, we had another opportunity to come before Travis County Commissioners Court. So 5 presentations and work sessions. And then we also planned 3 community conversations, and that was Ted's team responsible for that. And also, you know, we brought in executives to present at those community conversations. We also had a public hearing and before our budget adoption, before the budget, the vote on the tax rate. And lastly, you know, our last deliverable was to obtain 4 votes out of 5, and we were able to get a unanimous approval of our budget. I do want to say that that in addition to this, we held many roundtable conversations with key stakeholders that I think also influence that alignment and support for our priorities and our budget, and lots of one-on-one meetings with stakeholders, with individuals who both have supported our budget in the past and who have opposed our budget in the past. And so I also want to acknowledge Pat for, really stepping up to meet people and to hear the criticisms and the opinions, and to just be open, and when we could incorporate that feedback into our priorities. I'm going to hand it over to Ted.
And I would say because of that work, some former critics are now strong advocates for our work, which has been really nice to kind of bring them on board and create ambassadors for Central Health. We can go to the next slide. One key takeaway for us, and I also want to acknowledge this has been a team effort. The communications team includes outreach, community engagement. Our community outreach workers are on the ground, and our government affairs and external relations team. So there are a lot of people that are involved in this work throughout the year. One of our key takeaways has been that sharing clear communication information consistently is vital. We recently completed a survey of Travis County residents. It's our biannual awareness survey. One thing that came through loud and clear is that the more information know about Central Health, the greater the support is for our mission. In fact, 94% of Travis County residents support our mission, and the same percentage believe that healthcare is a human right. And I think that's something we can take away on a day like today, when some of us may be feeling discouraged. There is overwhelming support for the work that we're doing. We also tested a variety of messages, facts and messages. After hearing those messages, 75% said their impression of Central Health increased. So that tells us, I know the messages that we're using and disseminating and sharing are working. And of course, we continue to fine-tune those messages as we go, and tell stories that are fact-based, data-driven, but perhaps most importantly, patient-focused and staff-focused. And you're seeing the results of those today, even with the Bridge Clinic presentation. I think our staff is incredible, but the patients that we're caring for are even maybe more impactful. So some of the key learnings that we took away, one was for budget communication, we really need to always simplify our budget communications. It's inherently complex, but we've got to be clear and concise. We had an anecdotal lesson taught to us during one of those roundtable events where we had prepared a budget fact sheet that we thought was brilliant, and we shared it with the people at the roundtable, and some folks just said, whoa, like, what does this mean? And so I think sometimes because we live this every day, day and night and weekends, we may take some things for granted, but we've got to make sure that we're meeting people where they are and not expecting them to meet us where we are when it comes to communications. So that was a real learning experience. Just, not that we don't know it, but it's helpful to be reminded of it. We need to continue to leverage patient stories and staff testimonials. I hope that all of you follow us on social media, follow us on our website, in our newsroom, which is a relatively new feature on our website. But I think hopefully you've noticed, and I also want to thank Pat for helping push this to happen more and more, like always making sure we're telling those human stories. And I hope that you're seeing that in all of our communications, including our communications with Travis County Commissioners, where we actually had patients come and either in person or in video provide testimony. We heard after those presentations that was very impactful and very helpful. And then finally, just to continue this collaborative strategy, including the roundtables that we started this year. We hosted roundtables with Black leaders, Latino leaders, women leaders, LGBTQIA plus leaders, and many, many more. And they got a chance to have FaceTime with Pat, have a conversation, ask questions. Sorry?
AAPI leaders as well.
Yes, I knew I'd forget one. There probably are more, but we're already scheduling those out to continue because they were very, very well received. And including our community health champions, I don't ever want to forget that group. They are so vital to the work that we do. We now have probably upwards of 400 community health champions that have been with us for the past 8 years. These are our core amplifiers. We keep them in the loop. We can turn to them when we need help. When they have questions, they come to us. And so I think it may be a unique program for any hospital district in the country. And I didn't create it, but I love to champion the work that they're doing.
And I think another action plan, and actually this is something we've discussed with Manager Masaitov, is getting board input into the process where we gathered board proposals for budget development. And so I think we're going to be doing some of that at our meeting next week.
Thank you.
All right, so just bringing us home, thank you for allowing us to review these 6 early wins for trust, Chair Kitchen. It's been an incredible privilege to be here with all of you in this year and to see our teams keep the work moving. I'm learning a lot about the amazing aspects of our community and how vigorously we believe in what we believe in, and we engage in conversation. And the politics can get a little raucous sometimes. And one of my reflections has been that through all that experience, our teams have continued to stay on the ball and run the ball and move the ball. And I think you see that reflected, at least at the sort of top level of our highest priorities here. I want to add that what you see reflected here is going on across the board, up and down and across the organization in ways that just make me so proud and appreciative of our team. So I wanted to offer that thank you to our broad team and to our executive team and to all of you. Hopefully the priorities that you've lifted up, ranging from homelessness to mental health, care in the Eastern Crescent, ensuring that we are being thoughtful and meeting all of our communities of color where they are, expanding our partnerships, thinking about all the interconnectedness, learning about our peers in other cities and so on. So thank you for pushing us, inviting us into these spaces, and thank you for the opportunity to share our experience in these first early wins for trust.
Thank you, Dr. Lee. What I would propose, if it's okay with the board, is we have these great slides that we can take with us and digest, and then we can we'll put another item on the agenda in the future to ask questions, just in the interest of time, because we have 2 more items for discussion. Is that acceptable to everyone? yeah, I'm seeing that. This is, and let me just say, I think I'm expressing the sentiment of everyone on the board. This is very impressive, not only from the perspective of helping us hone in on digestible for us wins, but it's done in a way that that you're covering the purpose, the value, and you're tracking it. So, and you're telling us learnings. So I think this is very, very helpful for us. And so please understand that this is really good backup information for us. And we will follow up. Okay? Okay.
I would just recommend, because of the value, when we have these type of presentation, we really need to allocate enough time for us to have the dialogue. Inserting it in.
Yeah, I think that's been a challenge for us, particularly lately because we've had so many important things on our agenda. We had to take care of the Sendero thing, for example, and that took maybe longer than we had anticipated. But I hear what you're saying, and we will work to do a more targeted or exact job of allocating the time. So, okay. All right, we're going to now move on to items 3 and 4 and go into executive session for them. And just as I said before, these are informational items today, and when we get to them, I'll explain that more. So, okay, item number 3 is receive an update from council on the impact of certain state policies on MAP membership. Item number 4 is deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal, or one or more Central Health employees, including the CEO of Central Texas Community Health Centers, DVA Community Care. So, let's see. I announce that the board is convening in closed session to discuss agenda item 3, under Texas Government Code 551.071, consultation with attorney, and agenda item 4, under Texas Government Code section 551.071, consultation with attorney, and under Texas Government Code section 551.074, personnel matters. Okay. Are we ready? Okay, I'm going to take us back in while you're looking for that. Let's see. It is November 6th, and the time is 5:48, and we're entering open session. The last item on our agenda is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is scheduled for next Wednesday, November 13th. Here at the Central Health Administrative Offices. At this time, I'm ready to accept a motion for adjournment from, what time is it, Brianna? It's at 4 o'clock. Yeah, appointments at 3, this meeting at 4, okay. Motion by Dr. Brinson to adjourn, second by Manager Montwani to adjourn. All in favor?
Aye.
Okay. Thank you all.